So we welcome you all. Now we are going to start the first talk, not John talk. Dr. Ramlal Sharma, he is in Shimla, the beautiful place, and he will be speaking on SICS direct step tunnel.
Good morning. Thank you, Dr. Mathur. I also thank AIOC committee for giving this opportunity to our society, that is North Zone Ophthalmological Society, and do thank all our colleagues of the North Zone for providing this platform to all of us. The problem with the session is that we have speaker, panelists, but no audience.
Everywhere.
That's something unfortunate part of it. It is probably due to one of the reason is that it's away from the main site, that we have lot of crowd there. I think one of the purpose is to convey it to the people rather than speaking there on the dais. So whatever it be, that's my opening comment. The SICS is one of the popular surgery as far as the cataract is concerned. Its different technique, its advantages with all its simplicity, safety, easiness, quickness, and flexibility, and of course reasonable cost and good visual outcome. In good number of complicated cases where phaco will be difficult for the beginners, it's always to do the SICS, provided you are comfortable with, as the most of surgeon of my generation. I'll be just showing you two videos that will, if they run simultaneously, both of them are on small incision cataract surgery with a simple, easier technique. That is, you just go like phaco emulsification. This is the posterior limbal incision. Just you put a stab incision, and you can do phaco also, and you can do small incision cataract surgery also. I just wanted that, do we really need all sorts of complicated steps? Maybe there are limitations to it that we do routinely for the small incision cataract surgery, which is taught as a standard procedure. Create a conjunctival flap, do cauterization, put superior rectus suture, and then create the crescent knife surgery and all sorts of steps. You can, I think, bypass it in good number of cases, or in all cases. In some of my senior residents who are doing it, I ask them straightway to go for it, bypassing all the steps. There could be 2-3 limitations or questions they have been always put for this technique by my different colleagues, but most of the time it works well. That is, you can see I can still perform phaco emulsification if I wish. On this case, as the incision is posteriorly placed, and there is some bleeding that happens in these cases, and not even a single drop goes in. That's the one thing that one would think that it might be lots of bleeding there, and it will enter inside the anterior chamber. As you can see, capsulorhexis capsulotomy is completed. This is one thing I did probably. The extension cuts were given 2 or 3 extension cut, and the larger rhexis was made. If it is a smaller one, no issue. Give 2-3 extension cut, it doesn't go anywhere. If it goes in hard, this is the extension part. Directly the same incision is extended without any issue. Usually we teach our students that the ratio of the length to breadth should be 50% of it. That is, if it is a 6 millimeter tunnel, almost 3 millimeter breadth is good enough to seal it. That is what I had seen, and it works well. The rest of the procedures, as you can see in one of my cases, it will be directly delivered as dissection, delineation, and delivery of the nucleus without anything. If the nucleus is harder one, as you can see on the other side, it will be delivered with just assistance of the vectis delivery. As you can see, it easily comes out. Bleeding is slightly more on outside. It looks ugly, but it doesn't at all interfere with your surgery overall. That is the visco delivery of the visco dissection of the epicortex, which is there. There is some injury in the iris. It doesn't matter at all. It will stop by the time the surgery will be over. This is a real-time unedited video The total surgical time will be taken almost 4.58 minutes, that is almost hardly 300 seconds surgery without any addition in these two videos. In hard categories, there was slight zonular weakness in these, and both of them were shaky. That's why I usually decided during the capsulorhexis that to go ahead with small incision cataract surgery or not. The surgery is almost completed. That is the beginning part, and now it is the implantation turn. And if it is a foldable IOL, then it can also be implanted, although it springs back. You can put it by injector, but many times these IOLs, they are spread from the center spray and they crack inside it, the cheap IOLs. So it's better to push them, not to take the risk of putting them into the injector system. That's why these IOL have been routed, and I directly implanted. Slightly difficult, it springs back, but it works well. As you can see, the surgery is completed within next 10 to 15 seconds, and my presentation will also be over. Since we do not have the previous speaker, if 1 or 2 minutes over is there, I will excuse from our panelist. So the surgery is completed. The last part which I would like to say, that put the injection, subconjunctival injection there. This is the how it balloons out. It neither pulls that will sufficient to seal it. If you wish, you can put air bubble, otherwise the surgery is over on both the sides. As you might have seen that it has taken less than 5 seconds. Post-operatively, they work excellently well. Sometimes there is a small hemorrhage, so these are the 5 steps. In conclusion, go for direct 2.8 or the 3.2 incision, extend it directly, go ahead, and finish your cataract surgery. And in complicated phaco, convert same incision into small incision cataract surgery. Thank you very much.
Very nice presentation, Dr. Ramlal. As always, you are doing lots and lots of surgeries, SSCS, and now phaco also. Himachal Pradesh is blessed to have you. Tell me one thing, what are the cases where you don't do stab incision, direct stab incision?
Of course, where I can do the phaco emulsification easily, pupil is fully dilated, it is a soft one, I go for phaco emulsification. Per se, I have not performed any standard SICS in last 8 to 10 years. That is by creating a flap, then by making this thing. If it is a easier one, go for phaco emulsification. Of course, if it is a difficult one, even in grossly subluxated cases, I do small incision cataract surgery. The recently case that operated last week, it was 50% zonular dehiscence, and still the IOL could be implanted into, of course, away from the site in the bag with small incision cataract. Works well.
I think it's a very good procedure. You have shown it, and it's very simple and easy to learn.
Yes, sir.
I'm almost doing the same thing with AC maintainer. I'm not using visco.
Oh, thank you very much.
Yeah,
Sir.
yeah, same procedure I'm following, same way. Stab incision, then extending it.
Okay, sir.
And
I just
only
want
thing I
that.
just want to confirm
Ji, sir.
whether your incision is parallel totally or you extend it slightly inside.
Yes, it is, sir. That's what I did not go into detail. It is just a single stab incision, so that no raggedness is formed. Actually, the leakage happens as a result of
Once
the.
you made a 5 or 5.5
Oh,
millimeter
yes,
incision,
directly.
then you don't extend it
And
or you,
only internal extension
Internal
is done,
extension.
just 1 or 2 millimeter on either side.
yeah, that I was seeing. It's not.
The most important part I wish to convey to the audience or to you people who teach the residents also, that why don't we go for this far simpler SAICS instead of the conventional that we have been teaching, as everything is evolving with passage of time. It works usually well. That's what my purpose is, sir.
And secondly, the beauty of this procedure is, there is no mark. Once you see after 1 week or 2 weeks, you can't make it out. Whether it is a SICS or phaco, you can't
doesn't-
make it out.
Any time you can convert it. Not
your-
yes, sir.
And your conjunctiva is totally preserved.
Yes,
So
sir.
you're not dissecting it anyway. So
Most important part, I would like that many of these cases, as I start them as a topical surgery, so it can be done even in topical anesthesia, and it works well, except for that intracameral phenocaine is needed sometime.
Thank you, sir. Thank you very much.
Thank you.
I welcome Dr. Gaurav Luthra, President, North Zone Ophthalmological Society. Kindly, sir, come on stage. Dr. Gaurav Luthra, sir. So this whole program is under the patronage of Dr. Gaurav Luthra ji and also Dr. Indramohan Rastogi. Our next speaker is Dr. Shakeen Singh. He is speaking on DSEC in challenging conditions. Dr. Shakeen Singh is professor and head at Shri Guru Ramdas Institute of Medical Sciences, Amritsar. Yes, sir. Yes.
Can I make working? Sound is coming?
Mike,
माइक चला दो भाई.
Oh, okay. Very nice presentation, Dr. Rampa. I just wanted to say whatever technique you have shown is very good technique, but how we have learned FACO transitioning from sort of ECC to all these things. If you go back to early 90s, there is a very beautiful paper by Ravi Thomas, who is no more now. It's published in Indian Journal of Ophthalmology. So what you do is initially give a stab incision, but if you have to convert later on into small incision, then dissecting the tunnel becomes a little difficult because eye is already hypotonous. So in that technique, what we used to do is you make a tunnel first and open only 2 millimeter just for the phacoprop. So that in case you have to convert to a small incision, it becomes much easier. Otherwise, dissecting the tunnel becomes much difficult if you just give a stab incision and later on try to dissect the.
I think we are running short of time, so we'll not do more of questions. Please, we can have Professor Shakeen Singh.
So good afternoon, everybody, and I must thank NZOS to give me this opportunity, and specifically Dr. Stanshu, and permitting me to speak before because I have to attend some other meeting. So my topic is DSEC. It's a manual in difficult situations. DSEC is the gold standard for endothelial failure, offering rapid visual recovery and a superior tectonic stability as compared to PKP. The challenges: while routine DSEC is standardized, many patients present with a significant anatomical or surgical comorbidities that elevate risk and demands tailoring strategies. So goal of this presentation is to systematically analyze the few difficult scenarios and share advanced surgical pearls to ensure predictable world-class outcome in the complex eye. So these challenges would be related to anterior chamber or a comorbidity of a posterior segment, compromised host tissue previous surgery, or a lens status or a lens fixation. So when you talk of anterior chamber, that may be a shallow, maybe an aphakia, maybe absence of a capsule, maybe a glaucoma drainage device is there. When you talk of the posterior segment, patient may be aphakic with a silicone oil or with a buccal or a active inflammation or a uveitis, and the host tissue may be post-PKP graft, host junctions instability, prior glaucoma filtration, or a corneal scarring. So lens can be an absence, aphakia, or with a abnormally placed lens, subluxated or into the anterior chamber. So challenge one, compromising anterior chamber. Dealing with this, we need to be very careful. Preferably, OCT is done beforehand so that you can take care of the anterior chamber when you insert the graft. It's away from the IOL or away from the iris. You should not stuck onto this or touch it and lead on to endothelial damage. And preferably, we can have a high viscosity viscoelastics or infusions. And we need to monitor IOL because the variation of the intraocular pressure would lead on to the change in the IOP and the touching of the graft tissue to the iris or the lens. So in aphakic and IOL fixation, we must see endothelial failure coupled with an unstable dislocated or inappropriately powered IOL is a major surgical event. The donor graft needs a stable, safe platform. Simultaneous procedure we have to do, triple DSEC or IOL exchange plus fixation. IOL removal must be done carefully to minimize peripheral anti-synechiae formation and iris trauma. DSEC first or IOL first. I would prefer IOL fixation first, then the dissect tissue. Maybe it's an RS claw, or you have to do scleral fixation when you don't have a PC support. Challenge 3, poor visualization and donor manipulations. The problem, dense stromal edema, a scarring or a highly epithelialized bullous keratopathy make donor insertion position and air bubble management extremely difficult. In these techniques, we pull through shove techniques, sling assisted, glass cannular injections. That's going to give you a safe injection and a placement of the graft in the anterior chamber. And extensive epithelial debridement, and sometimes we can use glycerin on the table to reduce the edema, or oblique lightening or retroillumination. Managing the posterior post-operative period, key to successful adherence and visual recovery, the big bubble, to ensure that the tissue is well placed, and we need to rebubble sometime, and SFS6 is a good alternative to air when it's not doing well with the air. Or a double bubble technique, when you have a segmental dehiscence, then you put a rebubble and place it there where the dehiscence is. So there are a few videos which would run through fast. So mind it, it's our manual dissects. So as we go with the crescent and then the dissector, your desired depth, thinner the graft, better it is. Thicker the graft, easy to insert and place. But there is a trouble with the visual recovery in the thicker graft, inter-host junction, interface errors. So thinner it is, better that. But that will lead on to more of the endothelial loss. So here you have a hazy cornea, deepithelized, being this is AC AIOL, so we would require a bigger incision very safely without damaging the iris. You take it one piece and ensure there is no vitreous in the PC, so you can either put the IOL in sulcus, but here we are doing retrofixation, iris claw. Then scoring, this is a post-failure dissect, and you size, most of the time you do it beforehand, like this was a post-dissect failure because of the anterior chamber IOL with the dissect, which was not a good choice. So you have to design what would be doing better in any patients. So I prefer a needle insertion, hence it's done, then you wash, and first you secure the suture wound so that there's no dislodgement or expulsion of the graft when you irrigate, and then the bubble underneath, it's going to settle it. I'll skip this manual dissection. So this step is, I would say, is important to note. Once you have dissected, you just see it's been thoroughly cut all across. So here we are fixing the foreclaw. This is going to give you much better anterior chamber stability, wherein we do not have a posterior capsule. It's well centered. Then you score the descimate endothelial complex. After marking the desired size, pushing in the graft, suturing, washing the anterior chamber, and bubble would settle it down, and make the patient lie at least half an hour in your OT, so that's been attached well. Very interesting case with a staphyloma, shallow anterior chamber, Herein we'll do the dissect procedure first. Scoring in these patients with a shallow anterior chamber is difficult, but you have to be very careful. Once you're done with the graft, then from the same tissue, you take appropriate size scleral partial thickness graft and you cover that. After debriding whole of the conjunctiva, making the blood properly, fashioned. This is the dissect with, this is the last video. I'll just finish in 1 minute. So here we have PKP, cataract. So you stain the capsule with trypan blue, make the posterior synecdoche clear so that you have enough size of the capsular axis. Though this is a very easy because of the steroid patients been using, the cortex is a softer to be aspirated, taken by the phaco. You don't need much power, but we need to be careful because it's been an inflamed eye all through. Making the anterior chamber deep with the visco, and you put an air bubble to wash out the visco now. Scoring the decimate. So it's better to mark the trapline when you cut the tissue so that you have a well stained margins that would make you graft clearly defined in the anterior chamber and to make it settle the way you want. So conclusion, predictable success in complex cases, preoperative ASOCT and the proper management of the anterior chamber, analysis during the slit limb. AC control is of paramount importance, like utilizing AC maintainer, high viscosity OVD to create a stable deep anterior chamber throughout donor manipulations. The triple threat, when combined dissect with IOL exchange fixation, prioritize posterior segment stabilization, first fix the IOL, then proceed with the dissect. Minimally invasive insertion, choose the safest, least manipulation insertion techniques, cannula pull through appropriate for the level of your visualization, and I believe we owe it to our patients to turn the most difficult cases into predictable success. Thank you. Thank you.
Meanwhile, I request Dr. Raman Mittal
Congratulations, sir.
to come on the
for
lines, please.
Very good collection of very complex cases. It requires a lot of talent and patience to operate such patients. So I think in case you were sporting the anterior staphyloma, we are using steel sutures, I think. There are steel sutures?
I have been using steel suture since long.
Since long.
So
Still you are using.
wound closure is always with steel sutures.
Still you are
Because
using.
still one suture is sufficient enough to close the wound.
Is it available in the market?
Pardon?
Is it available in the market?
Yes,
steel
it's
suture?
available. It's available. In the
Freely
market.
available.
Yes, it's available there now.
And it doesn't, you don't have to bury it, I think. It doesn't irritate.
No, just there are two techniques to apply steel suture. Either you have a two throws or a one throw.
Okay.
Two throws slightly difficult to manipulate. So one throw is easy, and you sit on the knot and cut with the vana.
Okay.
It's going to be stable there.
It doesn't
It's easy to
irritate.
open. It's a inert. There's no reaction you would find in the next day.
Thank you, sir.
Thank you.
Thank you, sir. Dr. Shakin Singh has just become member of AIOC Management Committee, And the second member from Punjab is Dr. Raman Mittal.
Thank you, sir. Thank you, sir.
Good afternoon, ladies and gentlemen. So, my presentation. Okay. So this is basically targeted to general ophthalmologists only, because there are few myths which are attached to ptosis surgeries and ptosis management, which way sometimes the patient is delayed for being referred to an oculoplastic surgeon. So here I would like to convey my feelings about those myths. Ptosis, as we all know, is referred to as drooping of an upper eyelid, whether it's in one eye or both the eyes. It could be congenital or acquired. And we all know that for ptosis, we have various procedures like LPS resection or tarsofrontal sling. So now, because of these two surgeries, there are few myths attached. The one important and the most common myth is that the patient cannot be operated at a very early stage or at a very late age, which is absolutely wrong. The ideal age for ptosis correction is preschool going age. That means less than 3.5 years also we can easily do it. That is the best time, because the child is going to school now and the colleagues around would be teasing him or her. So the patient will have some psychological disturbances and personality disorders if he is not corrected at this age. Secondly, about the late age, so I would like to say before that, an early age is, we can even operate it earlier than preschool going age if there is risk of amblyopia. Like in this child, both the eyes are so very ptotic that there is hardly any pupillary clearance. So in this, you can't and you should not keep on waiting till a particular age group. This child was operated by me at the age of around 15 months, that is 1 year and 3 months, and see how beautifully she is getting corrected, and the risk of amblyopia has decreased down significantly. We can even operate the ptosis at a very late age. So in this gentleman, it is a aponeurotic ptosis, senile aponeurotic ptosis. He was 90 years plus of age. So for him, lifting his eyelid was a challenge, and he has to use his eyebrows quite a bit. So throughout the day, if he keeps putting effort on the eyebrows, he would start having headaches. So correcting the eyelid at this age, at this time, is very important to make him comfortable. Second myth is with the Marcus gun phenomena. As we had been taught earlier, that Marcus gun jaw winking phenomena can't be improved without bilateral surgeries. In this, you have to do an LPS resection in both the excision in both the sides and then do a sling surgery. I beg to differ that it can be reduced considerably by doing a simple ptosis correction surgery like this. In this lady, she has Marcus gun phenomena, and post LPS surgery, the Marcus gun phenomena reduced quite a bit and the ptosis was corrected. In this, tarsofrontal sling was done, and as you see in this next video, on moving the jaw, there is hardly any blink phenomenon. So a lot of correction is there even with the unilateral surgery. Third myth is that scars are there which may be ugly enough, but I would like to say that the ptosis can be visualized from a very high distance, large distance, whereas scars, just in case any, are negligible or there is absolutely no scar. They are not visible as the patient, even if you look in a very close one, as you see in these pictures. So here also there is no problem, no scar. Blink is wonderful. So everything seems to be very natural in a post-operative case. As I've already shown the blink, it's very much there. Some people think that the blink won't be there, and that has been conveyed to the patient, and so they don't come for surgeries in a good time. Rather, they just try to avoid the surgery, but it's a near natural blink. As I would show in this case, pre and post-operative patient, and see the blink, how wonderful the blink rate is. And blinking is even present nicely in the bilateral tarsofrontal sling also, which can be visualized in this chap. He is blinking nicely and symmetrically. So the blink is not a problem. Even in this child of a younger age group with a unilateral sling, just 1 week post-op, the blink is quite okay. So the blink is not a problem. The last myth which I am going to tell you about is the nocturnal legophthalmos, which is that the eyes remain open while sleeping. This is again negligible, though it is present. In the initial first few weeks, it is much more. Slowly it reduces, and finally it is only in 1 to 3 months, it's hardly there. Like this girl who's been operated upon has a minimal legophthalmos, whereas the other girl who has both the eyes open, that is, no surgery was done, still both the eyes are open. So basically, it's not that the surgery leads to leg ophthalmos. Sometimes patient themselves have leg ophthalmos naturally. So it is there, especially in sling cases, but reduces drastically over the period of weeks or months. Thank you very much for your patient hearing. I think I saved the time also.
Thank you so much for finishing in time. Just one small question, what is your procedure of choice in very young patient and very elderly patient?
So that's a wonderful question, but age is not a defining factor primarily. Primarily, the LPS action is the deciding factor. If the LPS action is very poor or absent, then we go in for sling type of surgeries. If the LPS action is good, generally in the elderly patient, it's senile aponeurotic. Aponeurotic means the LPS actions are good. So LPS type of surgeries, LPS resection, advancements, plications are the preferred modalities. Where there is a poor LPS action, generally the patient will present early, whether they reach an oculoplastic person or not, that is a different thing. So when there is a poor LPS action, even if you do an LPS surgery, it won't be effective. So in those type of cases, slings are important. So it is mainly dependent on the LPS as well as the severity of ptosis than the age. So we can do sling and LPS at either of the age ranges.
Thank you very much.
Thank you very much.
Dr. Sangeet Mittal, are you ready, sir? The next speaker is Dr. Sangeet Mittal.
Dr. Sangeet Mittal is a very energetic VR surgeon, and he is doing a wonderful work in macular hole surgery. So he is showing macular hole surgery, no gas, no positioning, no problem.
Thank you, Dr. Karamjit. Thank you, Dr. Vinod, for giving me this opportunity. In fact, my topic is though it is no gas, no, it's same, but it's misadventures in macular hole surgery, and it's a miss spelled by double S. So, so this is my normal.
After raising the ILM flaps, they are stabilized and inverted under the PFCL bubble. Fluid air exchange is done and gas is used as a tamponade.
And this was like the post-op, and almost like 138 cases in the past few years, almost 100% closure rate I got doing this procedure. But suddenly, I was very happy doing this, like in this patient with a giant macular hole. I followed the same procedure. By a gas tamponade. And this was 3 weeks post-op ILM plea with flap, with PFCL, with gas. The hole had closed and the patient gained good vision. But suddenly I saw that a ghost struck my OT and I started missing things one by one. And this was the first miss. I missed my gas. Suddenly my assistant told me when I was operating that the gas had finished and I have run out of gas and now what to do. So this was the
PFCL was used to stabilize the ILM flap, as which were then inverted beneath the bubble. Fluid was exchanged with air and closure was done without gas.
So I remember Dr. Eckhart used to close the eyes, close the macular holes with air only, and he never used gas. And I thought I'll try this, and I saw that there was no need of gas. Just with air, I got a good closure. The patient's vision had improved 6 to 12. And this was my next miss. That was a perfluorocarbon liquid. And again, my assistant, I think I had to really change him. He told me that PFCL you are using too much of them. We ran out of it. It's running short. So I missed the PFCL to stabilize the flaps. Okay, I thought like.
In a case of MD with coexisting full thickness macular hole, the ILM flaps were raised. Residual ILM was peeled At this point, I was told that our PFCL stock is finished. Fluid air exchange was started and the eye was tilted to one side towards the optic disc so that the flaps can cover the hole. Once the macula was dry, the flaps were covered with dispersive viscoelastic viscoat. Closure was done with air as tamponade. No post-operative positioning was advised.
So I thought like I'll just close it with the visco, I'll just stabilize them with viscoelastic because PFCL was not there. And this is 2 weeks post-operative. Again, the hole has closed nicely, patient's vision had improved. This was a patient with age-related macular degeneration getting a vision of 636. So this was my second miss, and I thought like, okay, but then third miss was there was no air. Suddenly my air pump froze, stopped.
PFCL was used to stabilize the ILM flaps, which were then inverted under the bubble. Viscoat was injected around the bubble. PFCL was aspirated slowly and more viscoelastic was injected over the flaps. Closure was done without any air or gas tamponade.
So I didn't use any air or any gas, and this was 1 day post-operative. I saw the flaps were covering the hole, but there was hole has still not closed. But 2 months post-operatively, the hole had closed, and the patient's vision again had improved. This is 4 months post-op. Best corrected vision was 624, and the hole has closed. So no gas, no air, the hole closed. Then one day I started doing my routine cases now this only, but then I stopped. There was no success. This was the fourth case.
ILM flaps were made and inverted over the hole beneath the PFCL bubble. Viscoat was injected around the bubble. PFCL was aspirated slowly and more viscoelastic was injected over the flaps. Closure was done without any air or gas tamponade.
So this was 2 months post-operative. The hole was still open, but the flaps were still falling over the hole. So I thought like maybe I advised the patient, maybe we need to do another surgery, we have to inject gas. But then again, 3 months post-operative, patient was not ready for that. We waited another month, the flaps were covering the hole, and 4 months post-op, the hole had again closed. So now I thought like I did nothing but just covered it. That there was a flap which is working, but this was my last miss. There was no flap. This was a patient with a macular hole. Vision was 618.
Both ILM and overlying ERM were peeled together to raise a flap. While trying to trim it with heat cutter, the flap was lost. Residual ILM was used to cover the flap again. Unfortunately, the flap was lost again. A thin epimacular proliferation tissue was seen. I tried to cover the hole with this epimacular tissue using the viscoat. Closure was done without any air or gas tamponade.
Here we lost the flap twice in this patient, and this is 1 day post-operative. The hole had closed, so I don't know what was working in these cases. This 2 months post-op, patient's vision had improved to 6/9. So whatever said and done, I remember what Dr. Kelly and Dr. Wendell used to do when they started macular hole surgery. No ILM peel, just do the vitrectomy, and the holes, their holes used to close. But I think just to improve our chances, we are now overdoing the surgery rather than undercutting the procedures. Thank you. Thank you.
Thank you, Dr. Sangeet. So excellent videos as ever. So, and it's a very good idea if you have no gas or you can use air as tamponade to close the macular.
So presently I use air as a tamponade. I don't leave them just on viscoelastic. I use viscoelastic to stabilize the flaps, and I use air as a tamponade.
So wonderful presentation, Dr. Sangeet. As always, no wonder why you are getting all the awards and everywhere, be it international or national platforms. So great videos. But I would like to know, you say on a large macular holes you are doing these surgeries. What large? Is it 600 or 1000 microns? What?
So if it is a recent hole, then I don't stop. Even like one case that I showed was 1800 microns. I had done a surgery and the hole had closed. So a recent hole, I will operate every kind of hole. If it's a chronic macular hole, maybe only smaller holes I will try. In the larger
And
holes, I will
regarding
not try.
positioning, no positioning you are.
I don't give, I ask them not to lie straight. I don't give a strict prone positioning. I ask them either they can take any side or they can lie prone, but no, don't lie straight. That is the only position
Dr. Ramlal Sharma wants to ask.
We are running short of time.
Sir, we have lots of patients on my follow-up with partial hole with visual acuity of say around 6 by 24 probably progress, and their age is beyond 85. Reasonably satisfied with one eye or with this vision. What I should have advised to them, not probably reluctant to surgery until I motivate them to do or go ahead with it.
So what I understand from your question is you're asking they are partial thickness holes, not full.
With reasonable vision
reasonable
at
good
the
vision.
85 age year.
So sir, I never force my patients for surgery. I just only if they demand surgery in these type of cases, I will go ahead with the surgery. If they have complaints like metamorphopsia, and I will not take them for the surgery in the first go. I'll ask them wait for 1 month, and if I can document progression, and if the complaints persist, I may then go ahead with this.
That's what I suggest.
Yes.
Thank you very much.
Thank you, Dr. Sangeet. Thank you. Our next speaker is Dr. Urmil Chawla. She is speaking on canalicular obstruction, newer modalities of management. Dr. Urmil.
Good afternoon, everybody. Thanks to NZOS for giving me the opportunity. So, we all have been studying about NLDOs in congenital cases and everything. And canalicular obstruction makes a separate part beyond NLDO. So I'll just be covering, and this part would not only for the oculoplasty surgeons, but there are things that a general ophthalmologist can also take care of. So as we all are aware of the normal anatomy of the lacrimal drainage system, we have the two puncta, the canaliculus, and forming the common canaliculus, and finally the lacrimal sac and the nasolacrimal duct. So when we classify canalicular obstruction, we can do that in 3 parts. That is a proximal obstruction, that is just close to the punctum, up to 2 to 3 millimeter from the punctum. The mid obstruction, that may be from 3 to 8 mm from the punctum, and the distal obstruction. This is very important because the management differs according to this. Further, how do we diagnostically see? In proximal, we can measure it with the help of a probe. In proximal cases, we find the soft stop or up to 4 mm. In the distal, it will, when you pass the probe through the punctum, the soft stop you will feel at 5 to 8 mm, and in common canalicular, it goes close to the lacrimal bone and it will be felt at the level of 10 mm. And etiologically, we can divide it into congenital, and more common are the acquired cases where inflammatory and infectious causes are very common. Trauma, drug-induced, systemic diseases, iatrogenic, and idiopathic also. Previously, the modalities that were being used in the past were proximal canalicular. For proximal canalicular obstruction, we were doing conjunctival DCR with Jones tube, and for the distal, canalicular DCR. However, these techniques did not pick up too much success because of the various problems they used to face due to the obstruction of the tube with mucus, migration or extrusion of the tube, blockage, surgery being complicated, having a learning curve, success rate being variable. So all these problems deviated the surgeon from these techniques. And finally, we also had simpler ways to treat, so why to go for the difficult ones? Botulinum toxin injection is one of the very, not very common, but can be done by an oculoplasty as well as a general surgeon in cases of canalicular block, in which we inject botulinum toxin in the lacrimal gland. It blocks the presynaptic release of acetylcholine, which is required for tear secretion, and hence it helps in the watering process. And it's a very simple procedure in which it can be done under topical anesthesia. The patient is asked to look down in an adduction, and the palpebral lobe of lacrimal gland is exposed. And with a 30 gauge needle, you can simply grow transconjunctivally and inject around 2.5 to 5 units of the Botox injection. Various review of literature studies have also shown success rate in it, and favorable outcomes have been found in cases of Botox injection. But however, since like all other techniques, pros and cons both are there. Pros being it's easy, short duration, any general ophthalmologist can also learn and do it. But repeated injections might be required, and dry eyes is one of the common complaints. Then came the laser canaliculoplasty. In this, this was the double V-shaped Bowman probe kind of laser, which had an upper end, which the connection for an endoscope, the laser fiber, and the lower end, which was used as the irrigation channel. So ideal laser must deliver sufficient coagulation and a good cutting effect, and the laser beam with a maximum effect on the top of the fiber and a minimum of lateral effect to protect the adjacent tissue. Holmium as well as YAG laser could be used, and obstructions were opened easily using the laser. However, in this also the limitations were the de-epithelialization of the canalicular surface, delayed or abnormal healing of the canalicular system, and it predisposed to cynical closure also. Then there was another instrument called the balloon canaliculoplasty. This was an alternative option for treatment of stenosis of the common canaliculus mainly. Minimally invasive, could be done under LA, and canalicular dilatation was achieved with 2 successive dilatation of 90 seconds with a 2 millimeter diameter balloon dilator. And various studies showed around anatomic success rate of 40% and a functional rate of 76%. Now, what I wanted to stress in this talk was the technique of trephination, which I have started doing for the past 4-5 years. I did a thesis also, and it has given pretty good results with an easy technique. Again, can be learnt and done by a general ophthalmologist also. This is a mini trephine which is available. It is a 21 gauge stainless steel tube which is of 16 millimeter length. It has a plastic handle and a hub and an intraluminal stellate which is present, and it can be used with a syringe also. It has other uses also, but for this, when we do a trephination, we also should have a mini Minoka stent with us for a good success rate, and mini Minoka stent, almost every one of us has seen it. It is a tube with a diameter of 0.64, and it has a collarate and a head bulb, and the collarate, it gets anchored at the punctum of the plug. A small video I'll show you about this trephination. Please, yeah. So you just do a please check the video. So after doing a punctum dilatation, you can just do a syringing on the table, and you will see for canalicular block, the fluid will be coming out from the same punctum. As we all know, in NNDOs, it comes out from the opposite punctum. For canalicular block, generally, you will find that the fluid is coming out from you pass the probe, and you do a diagnostic probing and check for the block. Now you take it out and measure it with the caliper, the length of the probe. That will give you a rough idea whether it is a proximal block, middle, or a distal. Trephination is most successful in distal canalicular blocks, and once in which this is a trephine, we have passed it through the punctum. It goes through it, take out the stellate, and just do a grooving motion. You just go circular fashion, and you will have a pop-up feeling kind of thing, and you will hit the bone. So in distal canalicular block, because the soft stop is very thin, it's almost at 8 to 10 mm, and you can do that, and you do a syringing, you will find that on table only patency can be maintained in most of the cases. So you can repeat a syringing and confirm on the table again that while doing the syringing, the patency is maintained. After this, you take out the trephine, and now you can go ahead, you have measured the block, you know it's a distal canalicular block, so 1 to 2 millimeter extra you will take of the mini Minoka stent. Cut the mini Minoka diagonally in such a way that the cut end is sharp, and you are able to pass it through the punctum. You pass it through the punctum, and a little bit of effort is needed to fix the collarate, and with the help of the probe, or sometimes even I have used a dialer sometimes, you push the collarate inside, and it snugly fits with the punctum. And this is how it's a quite simple technique, and we can go ahead with it. Next slide. Okay. So the steps I have already shown you. After anesthesia, you do a punctum dilatation, trephination, soft tissue is removed, and syringing can be done. This, you can see the mini Minoka stent, and that can be removed after 3 months, or often it gets removed itself also sometimes. So it relieves patient symptoms, maintains the anatomical patency, prevents progression to complete obstruction, and function is maintained. And when we have seen various studies, Kupion, NSDAS Act, and they have given very good results of trephination. It is a safe and effective technique, and as I said, it is more successful in cases of distal canalicular obstruction, especially those which are 1 or 2 years old in which inflammation has been found to be the cause often. So it's a minimally invasive procedure, shorter in duration, technically simpler, and aesthetically superior result, and there's no visible scar. However, again, few limitations. Stent extrusion may be there, pyogenic granuloma, though I have never had a case of that, but literature does mention it, and very, again, rarely false passage formation if you do it quite carefully. And success rate has been reported to be 52 to 92%. So I would just suggest that look for simpler ways and less invasive methods. Don't just jump to conjunctival DCR. Canalicular obstruction patients are a little troubled often because of the epiphora, and especially children, chronically ill or debilitated patients, where doing a conjunctival DCR may be a tedious process. Trephination can really be helpful, and though it might need some repetition, but it is simple and can be done as a minor procedure. Don't repeat it. Even if you want to repeat less than 6 months, there's no need to repeat. It saves time and reduces the stress for the patient and the surgeon. Thank you very much.
Thank you, Dr. Urmal. So as we are running short of time, we will take the questions at the end. So our next speaker is Dr. Sonia. Are you ready with your talk? Yes. She is speaking on managing cataract in medically unfit patients. Is Dr. Madhu Sharma here? Yes.
Yes. Good afternoon, everyone. I thank NZOS for giving this opportunity, and standing in front of my teachers is a very humbling experience, because whatever understanding I have about cataract or the patient care, that has been largely learned from my mentors. And so and also in front of all these stalwarts of ophthalmology, I consider myself as a very humble learner, and I'll be sharing a very small experience of mine with all of you. So I'll be talking on the topic which we encounter in our daily practice, that is cataract management in the medically unfit patients. Why this topic is relevant? It is because cataract is continuing to be a leading cause of avoidable blindness, and with increasing life expectancy in India and improved healthcare access, the elder population is increasing in India, and it is estimated that by 2050, more than 60 years of population will nearly double in India. That means that the ophthalmologists have to deal with cataracts more. And secondly, there is changing patient profile, that is more patients are coming with multiple systemic diseases. And cataract, after being evolved to a very safe surgery, we should not deny the surgery to all these patients. And whenever we deal with this dilemma that the patient is unfit for surgery, our role is to balance the systemic safety with visual rehabilitation. So we usually encounter this term medically unfit, where we have to recognize the importance that mere presence of comorbidity does not mean that the patient is medically unfit for the surgery. It is the unstable disease or the poorly controlled disease which makes the patient unfit. For example, recent MI of less than 3 months, BP of more than 160/95, blood sugars of more than 200, acute stroke or decompensated CHF. Such patients may experience postponement of the surgery and optimization of the patient before proceeding to the surgery. So I'll be sharing few case scenarios from our clinical practice. The first one is regarding the hypertension, which is highly prevalent in our society, and it is around 30 to 45%. And according to the AIOS task force, the BP should be well controlled below 160/95. But we also see the patients where the BP stay elevated even after regular medications. So we had a patient of 68-year-old male who was a case of long-standing hypertension from last 18 years on telmisartan and amlodipine, and he came with a decrease of vision in both eyes, right eye with 660 improving to 624, and left eye 636 improving to 612. And posterior segment showed grade 1 hypertensive retinopathy. Now the point is that on OPD visit 1, the BP record was 168, 176 by 98. He was advised physician opinion at the first visit, and after 1 week he again visited with 170 by 94. And he was advised regular monitoring, but the BP was around 165 to 175 by 90 to 100 at monitoring. And he was sent to the pre-anesthetic clinic, where again the BP was 168 by 96, and also a cardiology consult was obtained, which stated that patient is a chronic uncontrolled hypertension, and his baseline is 165 to 175 without any acute end organ damage. So surgery can be proceeded without under monitored anesthesia care. So patient was taken up for the surgery, and morning antihypertensives were continued. Anxiolytic was given to the patient, and minimal waiting time was ensured in the operating room. And surgery was planned under topical anesthesia, and continued pulse and BP monitoring was done. So the surgery went uneventful. During the capsular access there was a rise of BP to 178 by 100, but no IV antihypertensives were given to the patient, and the surgery went uneventful with the post-op day vision 1 of 612. Now the learning point was, should we wait for the ideal numbers of 160 by 95? So according to the literature, there are in chronic hypertensive patients, the cerebral autoregulation curve moves towards the right. That is, the brain becomes accustomed to higher perfusion pressures, and if we try to rapidly control the BP or rapidly reduce the blood pressure, it causes cerebral hypoperfusion, leading to stroke, syncope, and myocardial infarction. So it is advised that we should gradually reduce the BP over weeks rather than rapidly reducing the blood pressure. And in chronic hypertensive patients, we should consider baseline blood pressure, along with if there is any acute end organ damage, patient is asymptomatic, and after taking cardiology clearance, patient can be safely taken up for the surgery. Now the next most common comorbidity is the diabetes mellitus, which is again one of the burden we see in India. These patients come with the early presentation of cataract with dense and mature cataract. They have suboptimal glycemic control, and also they have CKD on dialysis patients. And from surgical standpoint, there are preoperative and intraoperative challenges that we have to deal in such patients, like poor glycemic control, higher incidence of diabetic retinopathy and diabetic macular edema, dense mature cataract obscuring the fundus view, and associated neovascular glaucoma. The intraoperative challenges, which include the poor pupillary dilatation, fragile anterior capsule, weak zonules, floppy iris in long-standing diabetes, and bleeding risk in cases of proliferative diabetic retinopathy. Another case scenario is for a mature cataract with diabetic macular edema. The patient was a 73-year-old female who came with a diminution of vision in OS and loss of vision in the right eye due to neovascular glaucoma. The posterior segment was not seen in the right, there was no view in the right eye due to mature cataract, and in the left eye there was grade of NS3 to 4. And so, but the OCT, although there was a poor signal strength, but it was suggestive of macular edema. So there was a clinical dilemma that we should proceed for the cataract surgery first, or we should control the VEGF activity first. So we went for the anti-VEGF injection first, because the key concerns were that the fundus was not visible, fellow eye was already having NVG, and there was a high risk of macular edema post-cataract surgery. So we went with the anti-VEGF injection with blood sugar optimization, and after that the cataract surgery was done. So OCT also showed that there was edema, though the signal strength is very low in the pre-injection phase, but post-injection, which was done after 3 weeks, the edema improved, and the patient had post-op vision of 636. Also, we deal with poor mydriasis, that is small pupil. Surgical challenges are poor visualization of capsular excess, increased risk of capsular tear, difficulty in nucleus management, higher chances of intraoperative meiosis. And that can be managed with pharmacological dilation intraoperatively using intracameral mydriatics, or high viscosity OVDs, or mechanical expansion using the iris hooks. Patient on anticoagulants is the another one. sorry, I'll be taking just 5 minutes more. And so patients, they are large, from last 2 decades, we are also encountering the patients with, who are on antiplatelet and anticoagulation due to cerebrovascular and cardiovascular diseases, in cases of stroke, post-stenting and prosthetic heart valves. Stopping therapy increases the risk of systemic thromboembolism, but from the evidence of literature, it shows that cataract is a very low bleeding risk surgery, but if in case surgery occurs, it can range from a simple subconch hemorrhage to vitreous hemorrhage, choroidal hemorrhage, and hyphema. But also continuation of anticoagulants does not significantly increase the sight-threatening hemorrhage according to the literature, and the most common complication is the subconch hemorrhage, which is self-limiting. So another case scenario was 72-year-old male who went PCI 3 years back. He was on dual antiplatelet therapy. A cardiology consultation was taken. They asked to continue the aspirin and stop the clopidogrel. Patient was planned for phacoemulsification under topical anesthesia. On the first post-op day, there was dense subconch hemorrhage that was seen in the temporal region. So the learning point here is that we have to prefer topical anesthesia over the peribulbar blocks or retrobulbar. Gentle conjunctival handling should be there, and we usually deal with all these medication anticoagulants nowadays. So in case of aspirin, we can continue the aspirin for the patient, and for the clopidogrel, we should take a cardiology opinion before. Next, I'll be this. Okay. Thank you, sir. Okay, thank you, sir.
Thank you, Dr. Sonia. So our next speaker is Dr. Madhu Sharma. She is speaking on bridging the gap strategies to prevent late presentation of glaucoma in rural area. Over to Dr. Madhu.
Yes, sir. Good afternoon, everyone. First of all, I would like to thank AIOS and NZOS for giving me this opportunity, and also I would like to thank all my teachers. My topic of presentation is bridging the gap, strategies to prevent late presentation of glaucoma in rural areas. Glaucoma is the leading cause of blindness and vision impairment globally, accounting for 8% of global blindness. The prevalence of glaucoma in 2020 was 80 million, which is estimated to reach 112 million by 2040. India accounts for almost 13% of all glaucoma cases in the world. Around 12 million people are affected, and nearly 1.2 million people are blind from glaucoma in India. It is estimated that approximately 90% of glaucoma cases in India remain undiagnosed. This is the example of a patient visiting in the OPD. The patient came with a complaint of diminution in vision in both the eyes. His vision was hand motion close to face in right eye and finger counting 1 meter in left eye. And the intraocular pressure recorded on GAT was 43 in right eye and 37 in left eye. He had cataract surgery done 1 year back in right eye, and left eye had grade 2 nuclear sclerosis. So the saddest part was he was operated for cataract 1 year back, and still the glaucoma was not diagnosed at that time. And if it had been evaluated properly, the patient could have had some vision. So the critical challenges in the management of glaucoma in India are delayed detection and poor adherence to the treatment. So the causes of delayed detection can be lack of awareness, inadequate screening and awareness programs, asymptomatic nature of disease in early stages, poor accessibility to diagnostic services, and missed opportunities to diagnose glaucoma by the ophthalmologist. And the causes for the poor adherence to treatment can be compliance-related issues, like side effect from the medication, cost-related issues, chronic nature of the disease, difficulty with medication schedule, and lack of knowledge about the disease progression. So to deal with issues, we have to raise the awareness. Social media platform can be used to spread the awareness, and newspaper and posters can also be used. We can conduct awareness walks and street plays. We can utilize the hospital waiting areas to spread the knowledge about the glaucoma. And to increase the detection rate, we can conduct opportunistic screening or at-risk screening, at least of the patient visiting the hospital for presbyopic correction or for the cataract surgery. And optometrists can also be trained to detect glaucoma during routine checkups to increase the case detection. And we can also use AI-based algorithms and teleophthalmology to diagnose glaucoma in remote areas. And also we have to improve the accessibility to diagnostic centers. So the teleophthalmology is utilization of electronic communication in ophthalmology to share medical information from one side to another. It enhances access to high quality, cost effective, specialized eye care in inaccessible remote areas. The uses of teleophthalmology in glaucoma can be used in raising the awareness for screening of the glaucoma, for diagnosis, monitoring, follow-up of the disease, and also to ensure the compliance adherence. So whenever the patient visit in the remote areas, the local health care provider will take the image and will share it with the ophthalmologist. Ophthalmologist, after reviewing the images, will give his expert opinion to the local healthcare provider. And the next biggest challenge is the adherence to the treatment. So the deterrents to poor adherence in India are forgetfulness, which is seen in almost 71% of cases, improper drug installation, unavailability of drugs, funds to purchase the same polypharmacy, and side effects from the medication. To address these issues, compliance barriers should be identified to provide a simple and specific solution. Proper counseling of the patient should be done and of the family members. We have to advise the patient to bring bottles at every visit and have checked them. And wherever possible, we should simplify the therapy to monotherapy and fixed drug combinations. And we should practically demonstrate how to put the drugs in the clinic. And we can also advise the patient to use eye drop administration aids and to use drug reminder systems like alarm, mobile apps, and SMS reminders. And also compliance can be addressed with the help of teleophthalmology. So the take-home message from my presentation is the blindness from glaucoma can be prevented by raising the awareness, improving detection rate, and also by addressing the compliance issues. So let's all unite in this World Glaucoma Week to spread the awareness and for glaucoma-free world. Thank you.
Thank you, Dr. Madhu. Our next speaker is Dr. Suresh Kumar Gupta, sir. He is speaking on FECO with TRAB.
Very good afternoon. At the outset, I am grateful to AIOC and NZOS Ophthalmological Society for the invitation and opportunity. I'll be speaking on combined cataract and glaucoma surgery, that is phacotrabeculectomy. By 2050, the number of people in geriatric age group will be around 1.5 billion, which is around 16% of the total population. And glaucoma will be affecting 111 million people by 2050. And all of us are going to encounter more and more patients having coexisting cataract and glaucoma. And it's a real challenge to manage these patients surgically to all of us. And management options for managing combined cataract and glaucoma patient is combined surgery, which can be simultaneous phacotrabeculectomy, or it could be sequential surgery depending on the severity of the disease, essentially glaucoma. If glaucoma is more severe, we go for trabeculectomy first, followed by cataract surgery. And looking at the literature, comparing two-stage versus one-stage surgery, in 53 simultaneous phacotrab with mitomycin C versus 53 eyes with staged procedure, what they found that they had almost similar reduction of intraocular pressure. So primarily it's surgeon's discretion and sometimes severity of the disease which decides the type of surgery, whether it's combined or your standalone or sequential surgery. So indication of combined surgery in my patients is if patient is having visually significant cataract as well as uncontrolled glaucoma with maximal anti-glaucoma medications, or visually significant cataract in a patient with moderately advanced disease with 2 or more medications when there is risk of non-compliance, or there is medically uncontrolled glaucoma with cataract that is likely to progress very soon to become significant. So it's better to go for combined surgery rather than doing glaucoma surgery alone. And however, combined surgery is not panacea for all. So we have to be very careful when we have patients with traumatic cataract and glaucoma, uveitic glaucoma, and cataract patients having NVG, and pediatric glaucoma and cataract, and post-PK glaucoma and cataract. In such patients, it's always better to do one surgery at a time followed by another surgery. Preoperative evaluation in glaucoma patients, the counseling is very, very important at the time of diagnosis as well as at the time of management. When we are planning surgery, we have to be very clear to the patient what is to be expected. Look, this is not simple cataract surgery, so we should never offer moon to the patient. We have to tell patient about the complication expected results, and the aim is basically to preserve vision and not recover vision in glaucoma surgery. We have to look at the systemic diseases also, and preoperatively we have to assess the pupillary dilatation, and it should be mentioned in the record of the patient that the pupil was dilating to 6 millimeter, 7 millimeter or 5 millimeter, and at the same time assess zonular strength and look at the specular microscopy for the counts of endothelial cells. And for actual preparation of surgery, the IOP has to be as well controlled as possible. Pilocarpine is one drug which has to be stopped at least few days before surgeries. All other drugs we are continuing, and we are just stopping a day before the surgery. Aspirin and anticoagulant, if patient is on such drugs, they have to be stopped. And at the time of surgery, you can give 20% IV mannitol, or you can do simple paracentesis, which will decrease the pressure before you enter the chamber. And why your combined surgery is more difficult than standalone surgery? Because of the myotic pupil, sometimes you have flaccid iris, pseudoexfoliation, and in angle closure there is narrow working space, and cornea can be compromised because of the long-standing high intraocular pressure. And local anesthesia, we should try to avoid unnecessary elevation of intraocular pressure. So we should try to give minimum anesthetic agent required, and we should avoid excessive massage as it can compromise already compromised optic nerve. Role of mitomycin C in phacotrabeculectomy. Since this is a combined surgery, this is not only trabeculectomy. So when you are combining trabeculectomy with any other surgery, like cataract surgery in this case, it becomes high risk surgery. So mitomycin C is a good option in such patient. So in one study they used 0.4 milligram per ml mitomycin C for 2.5 minutes, and at the end of 12 months of follow-up, what they found that there was greater reduction of IOP, and fewer medications were required, and lesser additional glaucoma surgeries were required in patients who were where mitomycin C was used. So mitomycin C has to be used whenever you are doing combined surgery. Other issue is whether doing one site versus two site phacotrabeculectomy, and the meta-analysis of various studies, 10 articles, 10 randomized control studies were compared, and it was found that there was no significant change in IOP reduction in patient undergoing one site versus two site phacotrabeculectomy. So it's basically surgeon's discretion. When I started, I was doing one site surgery. Now I have totally shifted to two site surgery, which is I mean giving me comfortable outcome. So small video showing steps of my surgery. So I use corneal traction suture with 50 Dacron. So it's always better to raise the conjunctiva with injection of paracaine injection, and the dissection become very easy. So this is formation of partial thickness scleral flap around 3 millimeter into 3 millimeter. Mitomycin C is being applied. So you have to apply mitomycin C to wider area to have lesser side effects of mitomycin C. It's applied for 2 minutes, 0.02%. Then thorough washing should be done so that excessive mitomycin C will come out, which has not gone inside the cells. So this is standard standard phaco emulsification is being done from the temporal side. Can you forward the video? forward it. Yes. So stop. So coming back to trabeculectomy site again, iridectomy has been done, and then scleral flap is sutured with 2 fixed suture, one at the apex, one on the side, and 1 releasable suture. I always use 1 releasable suture, and then conjunctiva is sutured like standard trabeculectomy. So frequent dosing of topical steroids afterwards is very important. In simple phaco, we give steroids for just 3-4 weeks, whereas in phacotrabeculectomy, it has to be given more frequently for at least 6 weeks, and careful monitoring of any complication. And if IOP is high, digital massage or release of releasable suture will do the trick. So carry home message is careful preoperative evaluation is very important. Mitomycin C should be used whenever you are doing combined surgery. 1 site or 2 site, again it's surgeon's discretion. Use of releasable suture will give you one additional thing to control the intraocular pressure in the postoperative period. Prompt recognition and management of complication will give you good success rate in these patients. Thank you very much.
Thank you, sir. Thank you very much. So our last talk is by Dr. Arun Kumar Jain. He is speaking on realizing full potential of aspheric IOLs based on asphericity of cornea and IOL. So this is very important topic in the current practice by the cataract surgeons as well as for the cornea people.
At the very outset, I'd like to thank North Zone Ophthalmological Society as well as AIC for giving me this opportunity. So my topic is choosing aspheric IOL based on the asphericity of cornea and the IOL. As we all know that the quality of vision depends upon the total amount of spherical aberration in the eye. I have no financial interest in the subject matter of the talk. So just to understand briefly, the total ocular aberration depends upon cornea and the internal aberration of the eye, which equals the total eye aberration, and just measuring corneal aberration without internal aberration is of questionable value because the quality of vision depends upon the total ocular aberrations, and we all know that the clinically relevant aberrations are comma and spherical aberrations. Rest of the aberration as of now we are not able to correct with the IOLs, and lower aberration, as we all know, are in the form of defocus and astigmatism. This account for approximately 80 to 90% of the optical aberrations in the eye. What about the higher order aberrations? The common ones, as I said, are comma and spherical aberration. They account for around 10 to 20% of optical aberration, and we can have up to 64 types of aberration, but that is usually, as of now, whatever machines we have, we can measure optimally these 2 lower types. Other are just noise in the machine. Our machines are not that sensitive, and as we all know, the most common is the secondary astigmatism, comma and spherical aberrations. And spherical aberration, as we all know, is either can be positive or negative type of spherical aberration, which is evident from the present figures. The positive spherical aberration is in the form of sombrero hat, and the other one is donut shaped. And also we know that what we see, the quality of vision is dependent on total wavefront aberration, which is a combination of defocus, astigmatism, comma and spherical aberration. So the spherical and defocus aberration are the only aberration centered onto the optical system. Astigmatism and comma, they are in the peripheral part of the vision. So the IOLs can correct only the defocus. Of course, the toric can be corrected with the toric lenses. So we can address only sort of defocus as well as the spherical aberration. And also we know that most of the EDOF IOLs are based on tweaking the spherical aberration of the IOL nowadays. And as we, in normal eye, the normal young human eye has positive corneal aberration to the tune of 0.27 to 0.3 micron, and the lens has a negative spherical aberration to the tune of minus 20 microns. So that combined together, it comes to a total, a sum total of around minus 10 micron of aberration in the young eye, which also accounts for a little bit of depth of focus. But with the aging, the positive spherical aberration, the negative spherical aberration of the crystalline lens goes towards, as lens keeps on hardening and the cataract develops, the negative spherical aberration of the lens changes into positive spherical aberration, which deteriorates the quality of the vision in the eye. As you can see in this picture, the positive spherical of the cornea and the lens combined together increases the spherical aberration, and the quality of image decreases. And this is again to show in the other profile, two gets combined to increase the spherical aberration. But once we, change the lens with the spherical aberration, it gets neutralized, and the quality of vision improves. So this is the one eye of the same patient, two eyes of the same patient. In one eye we have put a normal IQ lens, in other is the aspheric lens, and you can see the point spread function. There is a huge difference in the point spread function. The quality of vision differs a lot, and as we all know, the spherical aberrations can lead to decrease in visual contrast and higher glare sensitivity, especially during night time driving. You can see glare and halos around the light, and this is the normal aging sort of changes in the spherical aberration of the eye as we age. When we are younger, cornea is positive and lens is negative. With the aging process, both becomes positive and the quality of vision decreases. And based on this information, we can choose different types of lenses. Like this is the normal range, maximum number of people have to the tune of 0.3 microns, but post-LASIK or post-myopic LASIK or post-hyperopic, there is a huge variation in the spherical aberration in the eye. So this is the paper way back in 2007 by Cox et al., which they have shown that the optical ocular surface ocular spherical aberration and IOL spherical aberration for a 6 millimeter pupil varied widely between eyes with defocus of 0 or minus 0.5 or plus 0.5. Most eye achieve the best image quality at an total ocular spherical aberration of minus 0.1 to 0 micron, and with minus 0.5 focus plus 1.15 to plus 0.3 microns, and with the hyperopic focus, if you are aiming for hyperopic focus, the lens should have the total eye asphericity should be this much. So based on the corneal aberration, we can choose the IOL, and this is like if you are choosing if a cornea has this much of aberration, like positive corneal aberration to the tune of like 0.32 or more than 4, one can choose a defocus of either 0.25 quarter or minus, so that you get a good quality of vision. And this is another study where which shows that we can choose the IOL depending upon the positive and negative or aspherical spherical aberration IOL based on the corneal aberration. As we know, these are the most commonly used IOL. I'll finish within 2-3 slides more. These are the Gaussian norm lenses, aspheric neutral, which tolerates decentration, and regular IOLs have a positive spherical aberration, which is akin to the aging lens, and these are the lenses with the negative aspherical aberration. And this is the algorithm given for that. If we have a high angle alpha, we have to evaluate the optical alignment system because of angle alpha. If there is a not large angle alpha, we have to analyze the corneal quality of vision, and if there are low corneal aberrations, if there are higher corneal aberration, one can consider monofocal, and if we are using toric IOL, I mean if the lower aberration, higher order aberrations are low, then it can be a candidate for premium IOL. We can use a toric IOL or a multifocal IOL. So this is the optical, this I'll skip. This is not only the spherical aberration, even the tilt of the lens affect the quality of the vision, and it shows 6 lenses where there is a tilt, there is no zero, this is a lens with zero aberration with zero tilt. This is the lens, these are the different types of lenses with 0.5 millimeter decenter. As we can see with the aspheric lens, which is Gaussian norm, there is a minimal deterioration of vision with decentration as well as tilt. So I won't go into this, I will just give you one example. So this is one patient where the preoperative spherical aberration is around this much. This is the internal one, the corneal one is around 0.1, and this is the corneal spherical aberration at 6 millimeter, which is around 0.4, and I will come to that. And this is the modulation transfer function, which is less than 40%, and to have a good vision we should have a corneal MTF is good, but the total eye MTF, because of the cataract, it is less.
Sir, you have to wind up, sir.
Yeah, so on eye trace one can see that with this much amount of spherical aberration, we choose an IOL of Technis, which has a 0.27 micron of negative spherical aberration, and post-operatively you have a very less total spherical aberration of 0.07. So I want and the quality of vision is good. And this is one this is post-op. You can see the quality of vision has improved, and the modulation transfer function has also improved. This is another patient on eye trace which has a score of 8.47 of this eye trace, the dysfunctional index score, but there is no cataract, so it doesn't need, you have to look for angle alpha also. Like here angle alpha, if angle alpha is more, then you have to be careful about the multifocal or the other IOLs. So this is just to show this is preoperative patient with eye-enhanced IOL, and you can see the very high spherical aberration, and post surgery the total eye spherical aberration has come less and the quality of vision has improved. Thank you so much. So with the study of corneal and total eye aberration on eye trace or any topographic machine which gives internal aberration, we can choose an IOL which can match the eye, so that we can have a good quality of vision and good depth of focus.
Thank you, sir. Sir, as a general, what's your choice for hyperopic LASIK? What's the lens you choose?
Because hyperopic LASIK have the higher order of this negative spherical aberration, because we are making the cornea steeper, the corneal aberration become more the negative.
No, sir,
so we have to choose a lens with the which doesn't have which should have a positive spherical aberration.
Your choice of lens, sir.
Just so SA 6080, which has a plus.
We have to use a spherical, not the aspherical and hyperopic, and maximum negative in the myopic LASIK. Maybe a Technis 1 or like that.
We have to titrate the how much defocus also you are keeping.
Yeah, that's a general rule.
With defocus, the amount of spherical aberration which we choose will be different for each case.
Thank you, sir. Thank
you
so
much.
Thank you,
sir. Thank you very much. Thank you, chairpersons and moderators. And thanks to all the speakers for attending this North Zone Ophthalmological Society. Can we have a quick group photograph of all the chairpersons and speakers? I request all the speakers and chairpersons to come forward for a group photograph. All the members of NZOS also.